Welcome back to PedsCrit. I'm Zach Hodges, a pediatric intensivist in the University of Texas Southwestern in Dallas.
And I'm Alice Shanklin, a pediatric intensivist at Coed Children's Medical Center in New York.
And we are excited to be speaking with Dr. Jatinder Dhami and Dr. Steve Shein today on critical bronchiolitis. Will each of you please introduce yourself and tell us something about your clinical and academic interests related to today's topic?
So I'm Jatinder Dhami. I'm a current second year attending now at Rainbow in Cleveland. I did my medical education in New Jersey, and then I did residency at Penn State and fellowship at Riley Children's in Indianapolis. I'm interested in ethics, how that relates to critical care and how we provide management to our patients. I'm also interested in patient and family outcomes and how families interact with the system at large. And then in terms of how this relates to bronchiolitis, I feel like bronchiolitis is one of the most common admissions that we get as intensivists. And so these families will interact with the healthcare system quite frequently. And you're going to see at least one, if not a billion, bronchiolitics in your career as an intensivist.
Wonderful. Steve.
Alice and Zach, thanks so much for having us. My name is Steve Shein. I'm the Chief of Peds Critical Care Medicine at Rainbow Babies and Children's Hospital in Cleveland. I did med school and residency here in Cleveland and then was trained in critical care at the Children's Hospital of Pittsburgh. Here at Rainbow, besides being the division chief, I also co-direct our research program and until recently was the fellowship director, though luckily for our fellows, that is in much stronger hands of Dr. Andrea Socia now. And I'm also the holder of the Linsalata Family Distinguished Chair in Peds Critical Care and Emergency Medicine.
Oh, well, that's wonderful. Now, Jatinder, you've recently started your career as PICU faculty at Rainbow. And Steve, you've been the division chief for years. What advice do you two have for early career attendings getting started on their academic path?
So I'll say that I think in fellowship, you're on such a timeline. So you have 3 years. You have to figure out what your research interests are, gain all your clinical acumen, and then go into a new career. And then hope that those 3 years have given you enough wisdom to become a full-fledged intensivist. And that's really scary. So I would say that give yourself a lot of grace as you're starting your career. And that timeline that you feel throughout all of your medical education doesn't exist on the same degree when you're in attending. You have a lot more work-life balance. You're able to kind of dictate a little bit more of what your interests are and how you go through your research and your clinical life. And then I also think that don't ever forget that you're not in a silo. You have a lot of mentors, both at the institutions that you trained at, but then also at the institution that you're now at. And that really helps. And then give yourself a lot of grace. I think the first 6 months, I thought I was going to be, a hot shot new attending. And then I'm like, oh, actually, we do things a little bit differently here. And so it's a lot about learning the system as well.
Totally.
Yeah, I totally agree with that very wise advice that Jatinder shared. Definitely set yourself proper expectations for especially your academic achievements early in your career. No one gets an R01 in their first year. And frankly, most people by the end of their first year of being an attending don't even entirely know what they're going to be doing with their non-clinical lives. So to me, some of the key things that you can do when you're a new faculty member, be present. So be around the hospital, meet lots of people, try lots of things, say yes to lots of things to see if you like them. Go to meetings, go to Policy and FCCM and ATS and all those things and become part of the global PICU network and just try stuff. You're going to find things that didn't consider coming into your career that you're really going to like and that might fit a need at your institution as well.
Wonderful. We really love the virtual mentorship that many of our guests share with, Alice and I, but also our listeners. As we pivot to the topic of critical bronchiolitis, any relevant conflicts of interest to disclose?
Not for me.
Nothing for me either.
Wonderful. Alice, you want to give us our first question?
Let's do it. So we're all familiar with the typical presentation of bronchiolitis in infants under 2 years old during the fall or winter. You've got fever, rhinorrhea, cough, increased work of breathing. The diagnosis is usually clinical, straightforward. You don't need to do much. When we're evaluating an infant with fever and respiratory distress attributed to bronchiolitis, what history and physical exam findings support this diagnosis, and what red flags are you two just automatically screening for?
Yeah, so as Alice, you've already kind of mentioned, it is a clinical diagnosis, and oftentimes it's pretty straightforward. You're thinking of your patient population that's less than 2 years old. They're presenting with fever, rhinorrhea, cough. They have a few days of preceding symptoms, maybe a little bit of poor PO intake, and then there's sick contacts in the family. The red flags that I think about first, like even in just like straightforward broncholytic, is my favorite thing to tell all the fellows is do not trust a baby less than 6 weeks old because they can present as a straightforward broncholytic, but then there's actually like more things that are going on. And then there are the patients that are like premature, have a history of chronic lung disease. You have like neuromuscular weakness, like all those kids, even if they do just have straightforward broncholytics, are going to give you a little bit of a run for your money. And then in terms of like other diagnoses that we should be considering, I think of the patients that are presenting with like respiratory distress that have a longer history. Maybe they have a history of like poor feeding, or they have respiratory distress when they are feeding. They have poor weight gain. That makes me think of maybe a potential like undiagnosed congenital heart disease patient. A good intensivist is never going to forget sepsis. So if they're coming in with like altered mental status, they're having some like apneas, it might be a broncholytic, but it also might be someone that's presenting with sepsis and bacterial meningitis, or like the middle age, like in that age range, kid that kind of wasn't being watched by their parents, or they're quick, so maybe they got away and then all of a sudden have sudden onset respiratory distress. Then I'm thinking more like a foreign body aspiration. Steve, I don't know if you have other patients or things that you like to think about.
Yeah, so great question. It's definitely important to realize that while most things that have hooves are horses, as intensivists, we are going to see the zebras. Just off the top of my head in my career, I've seen kids get billed as bronchiolitis that turned out to have abusive head trauma, inborn errors of metabolism. I had a great botulism case a few years ago that was billed initially as bronchiolitis. So definitely keep your eyes open, especially for kids that just aren't behaving as you expect. And to me, actually, the kids that are the generally healthy kids who are acting sicker than I would otherwise think are the ones that I really want to have a broad differential. And that's also why I personally have a pretty low threshold for getting chest x-rays and labs and those kind of diagnostic studies in children that are admitted to the ICU with respiratory failure.
What a great teaser for later in the conversation. I will add, I feel like bronchiolitis is one of those diagnoses where there's quite a bit of diagnostic momentum builds up early on. And, usually these kids come, with multiple admissions over the course of the night. And for some reason, I feel like families try to keep their kids at home, as I understand, and they come presenting to the emergency department in the late evening and get up to the ICU in the early morning hours many times. And, as the ICU attending or the fellow, you kind of hear about these kids in the presentation in the emergency department. There are another broncholytic, air quotes, involved here. And I feel like there's so much opportunity for a diagnostic momentum that may cause us to be tunnel vision in the ICU. I think our job when these children present and show up to our unit, we really have to look at them afresh and think, what exactly are we seeing on our exam? What exactly are we hearing the family tell us that makes us so sure this is bronchiolitis? So maybe pivoting now to some of the pathophysiology here. What features of neonatal and infant anatomy and physiology make this population more vulnerable to developing bronchiolitis rather than the isolated upper respiratory tract infection that older children might have?
When I think of these kids, especially like your smaller babies, one, small airways and nasal passages, most of them are still obligatory nose breathers. They also have a much more floppy chest wall than your older toddler age children. And then just to get a little bit into the weeds of like pathophys, once you get a viral infection, either RSV, adeno, human metapneumo, COVID, you activate your innate immune system, which leads to the release of a lot of cytokines and chemokines. And then down that pathway, you get a lot of neutrophil and mononuclear cell infiltration into your airways. That leads to like airway sloughing. RSV even like disrupts like cilia, so even like airway clearance. So if you just think of these like small airways that already are cramped to begin with, and now you're adding all of this like debris into there, it just makes it even harder for them to facilitate getting any of that out, especially if you're disrupting the cilia. So that's what I think about when I'm thinking about the pathophysiology and some of the anatomical challenges with these like smaller kids and these lower tract respiratory infections.
One thing to add on top of that is there's also an advantage of the baby anatomy that we get to leverage at the bedside. So babies have a really large amount of dead space relative to their tidal volume, which is one of the reasons that, as I'm sure we'll talk about later, high-flow nasal cannula can be such a powerful tool in taking care of children with a diagnosis of bronchiolitis.
Steve, you and your colleague at Rainbow put out a great 2025 article in Chest describing the treatment of critical bronchiolitis. But really before that, and even despite it, we don't have a clinical practice guideline for critical bronchiolitis. Why is this such a difficult condition to study?
Yeah, great question. And the article that you're referring to that Dave Speicher wrote in Chest Critical Care, I thought was a really nice opportunity for us to kind of summarize kind of just our personal styles for managing children with critical bronchiolitis. But you're right, there's very few expert guidelines on critical bronchiolitis. Christophe Malessi and a bunch of French intensivists put one out a couple of years ago, but there's nothing that's endorsed by AAP or FCCM, though I'll admit me and a few partners did submit a proposal for one, so hopefully that's coming. But the main problem is that there's just not really robust evidence-based practices for critical bronchiolitis because it's been so understudied. And it's obviously not from a lack of patients. It is the most common condition that we see in the ICU. More than 40,000 children just in the United States every year get admitted to the ICU with bronchiolitis. So we have tons and tons of patients. We just do a pretty bad job studying them. And I think one of the main reasons underlying that is the inconsistency on how we define bronchiolitis, both for research purposes and clinical purposes. You can envision a child in your ICU who's a 10-month-old, who's wheezed a couple times in the past, who comes in with the classic symptoms that Alice and Jatinder were saying earlier, that has some schmutz on x-ray, and you get 10 different intensivists, and they're going to say 10 different diagnoses, and some people are going to say bronchiolitis, and some are going to say reactive airway disease exacerbation, and some might say viral pneumonia, or just respiratory failure. And these inconsistencies then lead to people not realize they're talking about the same patient, even though they're using these different terms. It's just led, I think, to a lot of inadequate data to support the kind of evidence-based guidelines that we do have for less ill children managed on the floor or in the emergency rooms.
Oh, that's great. And that reminds me of the way that we talk about drowning, right? If someone calls it asphyxia from water and someone calls it drowning, then it's hard to get all those papers together. It's like, it's the language, you think, and the culture surrounding the disease.
Yeah, even beyond that, like some children are intentionally excluded from some of the trials, even though to me, they're the ones that should be studied. So much of the literature on bronchodilators and steroids excludes kids with a history of wheeze. But a large percentage of children, up to 60% in some studies, admitted to the ICU, diagnosed with bronchiolitis, have a history of wheezing. And so we're sort of like, excluding the kids that might be most likely to benefit from these medications just based on the individual investigator's trial design.
Yeah. Leaning in more to the heterogeneity in critical bronchiolitis, we all hear about RSV and, there's almost an epithet of RSV bronchiolitis, but of course, many different viruses can cause the clinical syndrome that looks like critical bronchiolitis. I think about, SARS-CoV-2 causing bronchiolitis, and I think about rhinoenterovirus, which for some reason feels like it might be associated with more reversible bronchospasm. Please fact check me on that. Is there any evidence to say that we should increase our precision of medicine, so to speak, by treating any baby differently with critical bronchiolitis depending on what virus they have?
Yeah, great question. So the short answer is yes, there is evidence, but it's not consistent and I don't think ready for prime time. And going forward, to me, this is one of the holy grails of bronchiolitis research going forward. So as we all know, several different viruses can cause the clinical syndrome of bronchiolitis, with RSV currently being the most common, though that's likely to change in the upcoming years due to some of the new preventative products that are now on the market. But in terms of how they behave differently at the bedside, there's been multiple studies showing associations between rhinovirus and more reversible bronchospasm and subsequent asthma. So you might be inclined to say, well, if a child has rhinovirus, those are the children that we should be more inclined to try bronchodilators and corticosteroids. Except the most recent critical bronchiolitis trial that I'm familiar with of bronchodilators and steroid combination therapy came out of the Australian group published by Ben Gelbert in 2022, where they randomized children to both racemic epi and prednisone versus placebo. And in their subgroup analysis, it was actually the kids with RSV that benefited from therapy more than kids with non-RSV. And so I do believe that there are differences based on viral etiology for how these children present and probably how they likely respond to certain medications and interventions. But the reality is in 2025 is we don't actually have enough data to use that at the bedside, other than the obvious of, something like Tamiflu for a child with influenza.
Ooh, I have two follow-up questions. So my first is, when you read the study comparing racemic epinephrine and a steroid to supportive care, were you surprised that they chose racemic epinephrine over albuterol?
I was not really surprised and actually very, very grateful. As I think we'll probably get into later in the talk, I actually have a strong predilection myself for racemic epi over albuterol because of the fact that you get both beta agonism and alpha agonism. And the reason that they chose that in part was because of a study that's now probably like 15, 20 years old that came out of the Canadian ER trial group that suggested benefit of combined therapy with racemic epi and steroids in children in the ER setting with bronchiolitis.
Oh, that's exciting. That was one of my big changes from DC where I never saw it used to co-ed children's where we use it quite frequently. My other follow-up question is, and this is sort of related to Zach's initial question about precision medicine and the utility of the RVP. Sometimes the Gen Peds residents, they're stressed about the finances of the hospital, and we ask them to order an RVP for our critical bronchiolytic, and they're like, guys, come on, I'm feeling bad spending all of the hospital's money. Do you have a canned response to that? How do you think about value here?
Yeah, so great question. And I think it comes down to a lot of kind of local practices. Here, we still use some of those results for our patient cohorting because we have shared rooms, not in our ICU, but in our general wards. And so often they'll try to pair children with like viruses together. At the end of the day, the child that got admitted to the ICU is being charged if they're actually paying full price out of pocket, which obviously no one does. And we don't have time to get into all the nuances and complexities and inadequacies of American healthcare. But general billing for a critical care bed is usually $10,000 to $12,000, even higher in some places. And so adding the extra, $100 or so for an RVP is the proverbial drop in the bucket. That also being said, if you're not going to do anything with the results while you're getting the test, so if you're not going to actually use the fact that the child comes back for human metapneumovirus to guide the choices of antibiotics or not, or patient placement or not, then probably doesn't add any value, just adds costs.
Yeah, I think the other thing is that sometimes like families are very interested in knowing what virus it is. And so I've had the experience both in fellowship and as an attending where families are like, well, what virus is it? Why aren't you telling me like what's causing the problem? And that then comes down to like really good counseling that like there are maybe like 3 viruses that we have like a little bit more like targeted therapies for that we've already tested, and anything additional like really doesn't provide like clinical change. And some families are satisfied with that answer and some families are not. And so I think like as an intensivist, like you have to like, kind of navigate a little bit of that. I do think like sometimes like knowing if, for example, if they had adenovirus, that also makes it a little bit more interesting only because I feel like adenovirus becomes really bad. So I think sometimes it's like good to know, but I agree with Steve. I don't think it really changes your clinical management. Maybe changes like a little bit of the counseling that you can provide to the family, but I don't think it adds to what you're going to be doing necessarily.
I think it's actually quite interesting if you have a patient where there's a little bit of diagnostic uncertainty. If their viral PCR is negative and you're confident in the sample, I feel like that's a nice little stopgap in your diagnostic schema. Like, how convinced am I this is bronchiolitis if on a swab out of their nose is viral negative?
Yeah.
Like, I feel like that's a common pitfall. It's setting you up for like to missing out more sinister diagnoses.
Yeah, I agree. And I think that in a perfect ICU, you've already sat down with the family and you're like, tell me about day 1 of illness. Tell me about day 2 of illness. But sometimes there's just not time. So having that red flag in the chart. Yeah. The other thing going on this topic of my residents are like, really, Alice, when we get that x-ray, how are you using diagnostic imaging in your bronchiolytics with hypoxemic respiratory failure?
Yeah, so like the question is to x-ray or not to x-ray, right? So in my practice kind of varied both between like fellowship and here. Almost every patient that gets admitted to the ICU, I feel like at least warrants an x-ray because they're obviously a little bit more severe than the patients that are getting admitted to the floor. As we kind of talked about earlier, I think the differential diagnosis that we're considering, and hopefully we're not anchoring to just bronchiolitis, does like sometimes require a little bit more like diagnostic workup, and getting an x-ray, I think, both helps you in terms of like ruling things out or ruling things in. And then when you're thinking about who's going to be responsive to a bronchodilation, if they're seeing like hyperinflation on the x-ray, I think they're more apt trying that in that patient population. And then I always think of like, if this patient is not following their trajectory that I would suspect for a bronchiolytic, maybe there is something a little bit more going on that we're missing, and maybe getting a picture at that point is helpful. There have been a lot of QI projects that really targeted decreasing the frequency of getting x-rays. But I do think that, when you're getting admitted to the ICU, you want to keep your differential broad. You want to rule out big bad things. So getting an x-ray, although no one likes radiation, I think is still helpful in our diagnostic process.
Something I like to highlight for learners is that, typically bronchiolitis is an outpatient disease. And like of the kids who develop RSV bronchiolitis, we'll say a very small minority of them come to the hospital. And then of the ones that come to the hospital, a very small minority come to the ICU. So we're already selecting a very sick population where there could be many things like, pneumonia or et cetera, other things that need specific treatment. I want to highlight your point about when the baby doesn't follow that presumed trajectory for bronchiolitis. That's a really good idea to start thinking about, diagnostic imaging like a chest x-ray. It makes a lot of sense for a child to have a viral lower respiratory tract infection like bronchiolitis, maybe 3, 4, 5 days into the illness, developing a bacterial pneumonia. That would certainly explain a child who is perhaps getting a little bit better and then getting sicker again. We're also excited to talk about bronchodilators. It's already come out a couple of times. So we know that the treatment for bronchiolitis is mostly supportive care, but we are always so interested in doing anything that we can do to help the symptoms of these babies, especially when you start getting over 12 months of age. The real consideration, is there any kind of reversible bronchospasm here? Will you please tell us more about what the literature says about bronchodilators for this specific population of critical bronchiolitics, and then talk to us about albuterol versus other agents?
So as all the clinicians listening to this know, the vast majority of children with bronchiolitis have wheezing, at least intermittently, when you listen to their chest. But I think it's important to think about why they are wheezing. So to me, I kind of put the causes of wheezing in a child with bronchiolitis in 3 large buckets. So one possible cause is that they might have reversible bronchospasm. Another one is that they have swollen airways that are narrowed. And then a third one, as Jatinder was alluding to before when she was talking about the pathophysiology, is they just have junk and debris in their airways. And so when you're trying to treat that wheezing, you have to be treating one or more of those underlying pathophysiologies. So when you think about albuterol, which is a beta-2 agonist, that's going to treat the reversible bronchospasm, you might get the child to cough and that might clear the debris some, but it's not going to do anything to the swollen airways. But racemic epinephrine is both a beta agonist and an alpha agonist. And so there you get the added benefit that you're going to get some vasoconstriction, you're going to get some fluid resorption. So to me, if you're going to try a bronchodilator, I think the potential advantages of racemic epi outweigh the advantages of albuterol. Of course, when you turn to the evidence says don't use either of them. And that's what the AAP says. That's what the Canadians and Australian guidelines, that's really what all the expert guidelines say. But the problem is that those data come almost entirely from less sick children in the emergency room setting and in the general ward setting. And I think, actually, I know that most intensivists agree that there is a subpopulation of children in our ICUs that benefit from these bronchodilators. And the reason I say that with confidence is some survey results. So Adrian Zerka published a nice international survey a couple years ago that we abbreviated BEERS, published in Hospital Pediatrics. But even more so, because we don't always do what we say, if you look at observational data, about 2/3 of children in ICUs get bronchodilators. And so we all know the evidence. We all know that the AP says don't use these meds. And we're using them anyway because we all believe innately deep in our souls that we have the unique power to identify these bronchodilator responsive children at the bedside. I know I behave like that sometimes too. But the reality is that we don't have the ability, at least as of yet, to pick them out at the bedside.
Or on the x-ray,
Or on the x-ray.
Well, that's very validating that it's not just us, it's everyone. So you talked about when to trial bronchodilators. What can convince you to add a steroid?
Yeah, so great question. So I'll tell you how I used to practice and then why it kind of changed. So when I was growing up way back when, this was actually in the previous edition of the AAP guidelines, they suggested an albuterol trial. And what they meant by that, or at least the way that I interpret it, was that I would use my special pediatrician ears to listen to a child. I would then give them a dose of albuterol and again, use my special ears to assess whether or not that child had a response to bronchodilators, in which case they were a responder, and I would add steroids onto their care. The thing that really changed my practice was a study that came out now a number of years ago by Craig Schramm and Chris Carroll and some others at Connecticut Children's, where they tested the abilities of pediatric intensivists, PICU nurses, and RTs to actually assess albuterol responsiveness. They did this in a really innovative way. So they took children who were on the ventilator, so you could actually measure the resistance of the respiratory system and get an objective measure of whether or not that resistance improved after bronchodilators. And so they had kids who were intubated, who got albuterol. Some had a decrease in their resistance, some didn't. So they had a gold standard of response versus not. They blinded the PICU doc, the RT, and the nurse to that and had them listen before and after and say, was this child a responder or not? And they basically showed that we are as good as a coin flip. And this really kind of like shocked my world. And it's one of my favorite studies to teach about at the bedside, because the idea of listening before and after and using that to guide therapy, that really resonates, right? Like that should work. But the reality is that it doesn't, at least in any very reliable way. So personally, I tend to avoid steroids unless I am really, really convinced that this child's going to have a benefit, because they really do have an asthma-like phenotype. And I wish I could tell you exactly how I do that, because it's some very objective, evidence-based manner, but the reality is it's not. But I do think it's really important to realize that there are some downsides to steroids. For example, steroids have been shown by Asuncion Mejias and others to slow down how quickly children clear RSV from their airways. Obviously, steroids can cause hyperglycemia and hypertension, which frankly are not that huge of a deal for us intensivists, but they can also cause your patient to be agitated, to be super hungry, and all sorts of like behavioral things they have to consider too. So there are downsides to these medications. And one of the things that we as a field really need to do to move this forward is come up with some patient level factors that help us guide these therapies. But at the moment, we don't really have them.
Yeah, and steroids also, prolong viral decay. And so you're continuing to shed virus. Your also studies have not shown that like corticosteroids necessarily improve or shorten the duration of a mechanical ventilation. Of course, if you have like a more asthma phenotype and you're using both bronchodilators and steroids, studies have shown that that may decrease the length of mechanical ventilation. But if you're thinking of your run-of-the-mill broncholytic, there's not a good way to figure out who should or shouldn't get steroids.
Something we haven't brought up quite yet, but I think just intuitively, these bronchiolitic babies, they're angry, they're fussy, and I feel like it's part of the clinical syndrome. Like they're just so upset, their nose is stuffy, they can't breathe well. And you mentioned, corticosteroids may be causing some agitation, and then of course bronchodilators are going to cause increased heart rate. And I use heart rate and respiratory rate quite a bit in these kids just to monitor how they're responding well to the respiratory support we're providing them. So I want to just acknowledge that, if we're going to give these medicines to help treat a potentially reversible bronchospasm, we need to be really mindful of that we're going to expect some increase in the heart rate and perhaps even increase in the respiratory rate if they're upset. I think even as an attending, when these kids come up in the emergency department, they're so upset with just the transfer process. I try to just sneak in maybe 30 minutes later and examine them myself. And I think giving them enough time to metabolize the albuterol or the inhaled epinephrine or racemic epinephrine, we need to be careful to do that so we can get that reliable point of where they're at in their trajectory and how they're responding to their support.
Totally agree. I think heart rate is such an important factor for how stressed out the child is on their current amount of respiratory support. And the absence of tachycardia is almost always a sign that the child is best sort of like left alone on what they are, even if they look like they're working to breathe. And then you can very much lose that as a sensitive marker just by causing iatrogenic tachycardia from albuterol or racemic epi.
And I think this is like the one time the quote unquote ICU exam from the door is actually very helpful. And I tell like the, gung ho like residents and medical students that like before you even want to walk into the patient room, like these babies don't trust you. They've already been poked and prodded. They're usually being taken away from their parents that are their areas of comfort. And so their respiratory exam is going to vary markedly based on who is interacting with them. So sometimes just asking the parents to like lift the shirt and just watching what their exam looks like gives you a lot more clinical information than like being like, let me like rush to put my stethoscope on this child's chest while they're like screaming and seeing what I want to do.
In the ICU, we're always careful that we don't want to miss any patient with potentially sepsis. And pneumonia is usually what comes in here associated with bronchiolitis. And we have all these tests. We have x-rays, we have C-reactive proteins and procalcitonin and sed rate and white count, and et cetera. What is your clinical approach to deciding, am I going to start empiric antibiotics on patients with likely bronchiolitis, maybe pneumonia?
In my general approach, like most broncholytics, especially if they've already got x-rayed, like just leave them alone. The clinical scenarios that I think about empiric antibiotics or starting antibiotics is one, the kid who had been getting better and then all of a sudden is going backwards and their trajectory is not matching what I would suspect. If they have new fevers, new developing respiratory distress, new oxygen requirements, all of those make me think like maybe now they have a superimposed bacterial pneumonia, and that maybe starting them on like amoxicillin, or if they've had multiple hospital admissions, like on some Augmentin is probably worthwhile. And then the other patient population is going to be the kid that gets like intubated right? Like that's not stereotypical for bronchiolitis. The nice thing about having an endotracheal tube, especially once you've stabilized the patient on the ventilator, is that you can get a respiratory culture. While you're waiting for your culture to come back with either bacteria or no bacteria, giving them a 48-hour course of antibiotics, I think empirically kind of helps you navigate like, okay, like this is actually just bronchiolitis. I just need to wait. Or this is actually bronchiolitis complicated by superimposed pneumonia. And then the ventilator will also help you in terms of like, what is your airway resistance? What are your peak pressures doing? Things like that might also point you towards deciding about like, do I need an antibiose or do I not?
My practice is very, very similar. I almost never use antibiotics on non-intubated patients, but every child that I have that's intubated for bronchiolitis, we do a 48-hour rule out.
Wow, that's interesting because the way I think about it is, oh, if I could give this kid anything to avoid getting a breathing tube in there, right? Like that's what you definitely don't want. So
Yeah.
Yeah, and the truth is obviously way more complicated than I make it to be, right? There are definitely children who, Alice, your exact approach probably saves them from being intubated. The reason I feel very strongly about the if intubated, give antibiotics, in part because of actually some phys data that we published a few years ago, which showed that kids that got antibiotics on the first 2 days actually got off the ventilator faster, which from a database research standpoint is the opposite of what you should find, right? Like almost always in database studies, you find evidence that treatments are associated with worse outcomes just because of the treatment bias. So the fact that we found antibiotics associated with shorter duration, I thought was pretty moving. And like you actually have a way to get a fairly gold standard diagnosis because you're going to get an endotracheal sample from that fresh tube. I do agree that there are some children who are not intubated who giving them antibiotics is the right thing to do. It's just really, really hard to tease those kids out at the bedside, at least based on the current available literature.
Well, we've talked a lot about good classic PICU adjunct therapies here, but we haven't talked about positive pressure or respiratory support and what you guys are doing. So can you walk me through your clinical approach to starting non-invasive respiratory support and escalating it, including high flow?
I think everyone's favorite new toy on the market is high flow nasal cannula. I think we're getting a lot more comfortable using that as our primary modality for respiratory support in bronchiolitis. It's both comfortable for patients. There's a lot more ease with being able to like move patients from the bedside to the arms of their parents. You're not needing to put them on any anxiolytic like Precedex or anything like that to tolerate high flow nasal cannula. It also helps to wash out a lot of the dead space that Steve had alluded to earlier that a lot of our younger patients have and helps to wash out all of that carbon dioxide that's been sitting in the airway. Typically, I think most patients will start around like 1 and then escalate to about like 2 per kilo. There's not really good data to support that going higher than 2 per kilo on flow is necessarily like better. And so I think a lot of that is more like being at the bedside and titrating the high flow nasal cannula and seeing what does it do to the respiratory rate, what does it do to the work of breathing, your heart rate, and seeing like where you want your patient to be. And then CPAP and fellowship for these like really young kids under of like 1 year old, there was never a good face mask for CPAP. And then if you're thinking of like CPAP and these like really young babies, I think they're so tachypnic that it was often very difficult for patients to tolerate being on like CPAP anecdotally, I think. And then a lot of them would then require dexmedetomidine or a lot of consoling to even just like tolerate CPAP.
I want to dig into that a little bit more. You mentioned that there's not a good interface for the delivery of non-invasive respiratory support for CPAP. What have you guys' experience been with that? Because this is one of those institutional things that really continues to surprise me.
Yeah, so I think like between like being at Riley and then here at Rainbow, we do actually do a little bit more CPAP for our younger patients. I think the face masks that we have here are a little bit easier to like get them to fit well on the patients. And then at Riley, I feel like we just didn't have like the 6 month or younger, like there was just not a good mask that would get them to be like comfortable. But then it would always like surprise me because I'm like, everyone in the NICU is on bubble CPAP. So like
Pensacola Children's thing is that in DC, we'll put a face mask on an infant, and try, and it's all about the number that we have in the hospital. At the COED Children's, under 10 kilos, we're doing a nasal prong, right?
oh,
It's just,
interesting.
yeah.
Like, and I think for like the fellows that are graduating, like this is really like apt information because like just be based on like where you were for fellowship doesn't necessarily mean like that's going to be your practice forever, especially as they develop newer face masks. There's not like really good data to say like CPAP is better than high flow or high flow is better than CPAP. There are a couple of studies that show that if you need to like salvage, you can salvage with like CPAP for high flow or vice versa, but none of them really prevent those kids from being intubated. And the face mask thing, I think, is the bane of every intensivist's existence. Like, I want to use this, but I can't because I'm limited by what I have available to me.
Totally. Steve, what's your experience with this bit? Especially as a division chief, you must be making decisions, right, about what you have.
Yeah, though obviously things like this are always a team decision with our nurses and RTs and everyone else as well. But here at Rainbow, we're very much a high-flow nasal cannula shop. And as Jatinder was alluding to, this has been now well studied in children with bronchiolitis and also just PICU patients with respiratory failure, NOS. And really the data show that all in all, they'll give you equivalent outcomes. That doesn't mean that there's not individual children who would probably preferentially benefit from high flow versus CPAP, but there's really no evidence-based rationale for one being the top choice in your unit. So here we use high flow for the reasons that Jatinder was alluding to. It's easier, it's much more comfortable, and we have gotten ourselves very comfortable with watching children in fairly moderate respiratory distress on high flow nasal cannula, usually up to a max of 2 per kilo for a day or two, and avoiding putting them on positive pressure, whether that's non-invasive or invasive, and the sedation and other things that come with that. That all being said, if you work at a CPAP place, that's a totally reasonable approach too. And I think for anyone that's leaving fellowship or transitioning to a new institution for whatever reason, it's really important to both bring your personal experience and comfort, but also then see how things work at your new institution as well and learn to adapt to that model.
Yes. Respect your institution's culture of bronchiolitis escalation.
And then just put them on whatever is institutionally appropriate and don't look at them for 2 days and then come back and say, hey, everything is better.
Yes. Wait, I wanted to dig in on the high flow stuff a little bit. Steve, something I've heard you talk about before and something that you write about in your CHEST article is looking at database studies, right? Who's in the PICU, who's on the floor, maybe even from a division chief perspective. You see hospitalists starting high flow only in the PICU. You see hospitals starting high flow on the floor or the PICU. And then a little bit of clinical practice. When are you starting high flow? And is it for respiratory distress or hypoxemic respiratory failure? Can you speak on this?
Great question. And obviously, this is something that varies a lot place to place. So here at Rainbow, we only use high flow for respiratory failure. And so we only provide it in the ICU where you have a nurse to patient ratio and a doctor to patient ratio that enables you to treat a child that has an organ failure. There are lots of places that use it on the floor. And I think if you're using it for essentially symptomatic relief of respiratory distress, I think that's a totally reasonable choice. The issue is that children with respiratory distress can progress to respiratory failure, and doing so in a less monitored unit carries some risk. And so it really comes down to kind of individual style. And even what the cutoff is between distress and failure is a very, very subjective thing. It's sort of like the difference between dehydration and hypovolemic shock, right? So like floor has tons of dehydrated kids. The floor shouldn't really have kids in shock. To me, that's the same idea as respiratory distress versus failure. So I do think there is a place and a safe way to provide high flow in a less monitored setting. But if you're really using it for respiratory failure, if it's a child that if they inadvertently come off it because they, reach up and scratch their nose or whatever, that they are at any significant risk for having a respiratory arrest, to me, that level of care and that degree of illness is best provided in an ICU setting.
Yeah, I understand that. And I think making that distinction between are you treating respiratory distress, respiratory failure is really key. And I think that might not be clear to trainees when they come into the ICU, for the first time, and they go back to the ward, perhaps where they have access to high flow. And I think having these set of you can do no more than this much flow, this much FiO2 can be protective, but not 100%.
Yeah. And there are drawbacks, right? There's lots of evidence showing that institutions that have instituted high flow on the floor use it much more frequently than they did previously and without any improvements in outcomes. And actually even some data that their length of stay increases because once a child starts on high flow and now they need to be weaned off, which, as a quick aside, should almost always be done by an objective weaning protocol because that's going to improve outcomes. But there are places that don't use those or do them very slowly. So now you're taking a child who probably has already gotten over the peak of their illness, and now you're weaning their flow every 12 hours and extending their length of stay by an extra day or two.
Hey, before we move along away from high flow versus CPAP, I'd like to just get a few comments on how you define failure of your first line respiratory support strategy, and then what you might move to locally in your institution. And the reason I say that is we would really like to do what Jatinder mentioned earlier, put these child on high flow or CPAP, et cetera, and really just leave them alone for 2 days and let them get over the worst of the illness. But of course, they need close monitoring and they may have worsening respiratory distress, respiratory failure. And these kids have like an up and down clinical course where you can't really lean into like what's happening this particular moment too much. And then as you get to what to do after this has probably been the area of clinical medicine that's been of the most variability in our interviews thus far. So please tell us more.
Yeah, so I think in terms of like defining like when I think I need to like escalate to either CPAP or like intubating those patients, I usually tell the fellows that there are two instances. One, when you have refractory hypoxemia, you're up titrating your FiO2, you're now well above like 60 and you're still desatting, and now your patient looks a little bit more altered, is a little bit more mottled in appearance. They're probably a lot more hypercarbic than we would like to know. So that I think pushes me a little bit more toward trying to see if CPAP in this scenario can salvage me or if I just need to jump to intubation. And then in the younger patients, when they become apneic, apnea is not going to be treated with high flow nasal cannula, even though wishful thinking would hope that it would, because having a broncholytic on the ventilator is never fun. But apnea almost always pushes me towards intubation because those are not going to be like salvaged necessarily by like high flow or even CPAP. Obviously, you can put like a set rate on the back end on CPAP or even on like a BiPAP, but I think that those patients, there's something more that's going on than just your typical like wait on them, sit on them for a couple days. So those are usually when I'm like escalating my respiratory support for those patients.
Yeah, and I totally agree with those. With hypoxemia specifically, like if you're needing more than 60% on high flow and you're on your max flow, that's almost always a sign to try positive pressure ventilation because maybe that child needs their FRC reestablished. Apnea totally agrees its own kind of unique situation that is often going to need invasive therapy. To me, the hardest things are sort of assessing hypercarbia and work of breathing at the bedside. So obviously you can check blood gases, but that involves poking the child, and how accurate that is because the child's likely to be kind of screaming and fussing during that is certainly debatable. And whether or not mild hypercarbia should prompt a change, I would say probably not anyway. So really what you're looking for is children with severe hypercarbia, which often is clinically going to manifest as kind of listlessness and encephalopathy. So that's one of the things I'm looking for. And then in terms of work of breathing, so to me, it's somewhat about the severity of the work of breathing, which is obviously a very subjective thing, but even more so, as kind of Zach was mentioning before, it's sort of like the signs of physiologic stress of that work of breathing. So one of the favorite studies that I was able to be a part of was a project I did with Robbie Kamani a few years ago, a secondary analysis of one of his main study data sets, where the crux of it was these were a couple hundred children in the CHLA PICU that were clinically assessed by the doctor, the nurse, and the RT, including the subjective work of breathing as mild, moderate, or severe. And Robbie, being the cool respiratory physiologist that he is, had put in esophageal manometers in all these kids. So you had objective measures of the actual effort of breathing using the pressure rate product. And essentially what we found is that when clinicians say either no work of breathing, mild, or moderate, that the degree of increase in pressure rate product was all pretty similar and really not that crazy. But as soon as anyone in the room says severely increased work of breathing, it was those kids that had ridiculously high PRPs. So if I ever have someone say to me that this child has severe work of breathing, that always makes alarms go off. But beyond that relatively rare situation, because let's be honest, like most of the time the resident or fellow or nurse comes to you and says like it's mild or moderate to severe or something like that, is sort of like how stressed out the child is, especially when they're able to get as soothed as possible. And to me, in those situations, the child who's calm but severely tachycardic, those are the kids that need increased support. But a kid who's calm and working to breathe but has a normal heart rate and is alert, I'm almost never going to increase their therapy because, as I like to say, the child doesn't seem stressed out, so I'm not going to be stressed out. I'm going to continue to monitor. They're in a very closely monitored setting here in the ICU, and while they might worsen over the next hours or days, they're probably not going to. And if they start to show signs of inadequate support, that's when I'm going to usually try CPAP while also starting to think about like how we're going to intubate this child if they fail a trial of non-invasive support.
Art gases are really helpful in deciding when to intubate a broncholytic, because if they don't cry when you poke their radial artery, you better put the tube in. You know?
I like that way.
I love to get your perspective. So who are we using BiPAP on? What settings are you using? What interface are you using?
Yeah, so I think like BiPAP, maybe this is like me being like naive or personal like training. Like It's just either high flow or then you're intubating.
No way, really? That's cultural. That's interesting.
Yeah, it's probably not the right answer. There's probably like some patients that would probably benefit from BiPAP. And I think like what we were just talking about, the patients that have like severe worker breathing, the patients that are having like altered mental status, a little bit encephalopathic, a little bit mottled, have unexplained like tachycardia, are probably patients that I would trial like BiPAP on. BiPAP for us people that don't ever use it really like is not comfortable. And so you want to also think about how is this patient going to tolerate this now to like bilevel pressure that is probably going to be a little bit irritating. So I usually start low, even as low as like 8/4, and then like titrate up to effect, just because I don't want the patient to freak out and like worsen their respiratory status because they're now being delivered like 18/9 BiPAP pressures, and you're just like, that's not going to help them. And then it also is like a little bit of a disadvantage to them because you're going to be like, oh, they already failed BiPAP. Let me grab the ET tube. So always, I think like starting on the lower end and then working up, or if you have the ability to add a little bit of Dexmed in the background, it's nice to not mess up their innate respiratory drive, but just to provide some of the anti-anxiety of it all. I think that is helpful, but I think start low, be at the bedside, titrate to effect, make sure your patient is not worsening because they can't tolerate the pressures, and then be evaluating that patient like probably every 30 minutes to an hour to make sure that you're going in the expected trajectory.
Nice. Zach and Steve, what about you guys?
As Jatinder was alluding to, it's not a style that we use a ton of here at Rainbow. It is something that I'll usually try as we're at least getting things ready to intubate, because in my experience, there are some children that do benefit from it a lot. But in my personal clinical experience, the vast majority of children respond either to high flow or to CPAP. And those that don't, while it's certainly possible that they're going to respond to non-invasive, those kids, at least in my limited experience, have a pretty high rate of needing to be intubated, or at least getting intubated.
Oh, totally. Zach, what about you guys?
Well, we do try out BiPAP quite often in these babies. It does create an opportunity for a pitfall there because it's much easier to go up on the BiPAP settings than it is to initiate BiPAP. And I think it's a precarious situation where you're intubating a baby who's on an IPAP of 18 to 20 and an EPAP of 8 to 10. Like that's a very high risk intubation and something I try to stay away from at all costs. So I think the learning point is like if this child is not responding well to your therapy on BiPAP, I mean, I would be reticent to march it up very high before just committing them to an ET tube.
Yes. At DC, the protocol is if you could find a mask and you could get the baby to sync, that's great. 12/6, 14/7, 16/8 with hypoxia, and you're putting a tube in. At Coed Children's, there's a little bit more like personalization to the therapy, and we have really embraced nasal masks for the infants on BiPAP, and I think that they actually like it better. Like I'm like, I think it's good.
I like the nasal CPAP, like that. I think even for like your bigger sized children, like that was really well tolerated, because I think the anxiety of having something that covers almost the entirety of your face, or that alone, is like very terrifying. And then compound it with the fact that you're like sick and unwell in a hospital setting. The mask, I think, does make a difference in terms of both like patient tolerance and anxiety.
Oh, totally. And then the other things that we've covered on PedsCrit, but I personally haven't had the pleasure of using, are like a NAVA, where you're setting a NAVA level and then the BiPAP machine is doing its thing. And Buffalo uses negative pressure ventilation. Do you guys have thoughts about those two things?
Well, we don't use NAVA here. I think we've used it in one or two like rare instances where it's been like the chronically ventilated patient that you're trying to hopefully get off of, or like retrain their diaphragm, but not really like in their bronchiolitic population. Sorry, what was the second thing that you mentioned?
Oh, Buffalo's using negative pressure ventilation.
Yeah.
It's fascinating to me. Yeah.
Yeah, so like we never use that at Riley, negative pressure ventilation. I think towards the end of my fellowship, we had like one CVICU patient that was like a failing Fontan that had that. And then when I came here, we've actually used it like a couple of times, not in the setting of bronchiolitis specifically, but we have used it in like our neuromuscular patients that are coming in with viral pneumonia. So those are a little bit of an older patient population. And that has like helped a lot in terms of like preventing those patients from getting intubated. But I've not personally used it in like the bronchiolitic patient population.
And it's always really tricky because, as Jatinder alluded to, like we have both NIV-NAVA and negative pressure here at Rainbow. But because we are so comfortable with high flow, the only times we're even thinking about using those is for the kids that are failing, that are like declaring themselves to be the sicker patients. And so it's always that sort of balance of like, okay, so we have this thing that maybe can rescue this patient, but none of us really feel that comfortable with it because we don't use it routinely. So now we're going to start using it, but only on our sick patients that are like now at risk for respiratory failure and respiratory arrest. So it's always this chicken or egg thing. And like, I was here when we got the cuirass and we were so excited about it. And frankly, we don't use it that much because we don't use it that much, right? And then you talk to friends at Buffalo and they use it like water and they think it's the best thing since sliced bread. So I think it really comes down to the fact that so much of this is just based on local practice and customs. And while that there's value to that, at the end of the day, it's the same child, whether they're in the ICU in New York or Dallas or Cleveland or Buffalo. And their pathophysiology is not varying by zip code. And so us as a field need ways to hopefully one day figure out how to personalize these therapies. So it's not just because they happen to be in one state or the other. It's that we know that this child with this physiology benefits from this therapy.
Yeah, it's another highlight of the heterogeneity here and the opportunities to get better scholarship. As we zoom out a little bit, in the recent years, we've had the introduction of maternal RSV vaccination and then nirsevimab, and a long-acting monoclonal antibody given to infants to prevent RSV hospitalization. Is there any signal that this is affecting PICU admission rates for these kids, or we need more time?
Yeah, great questions. So the real-world data are just starting to come out. So there are some data that come out from Europe supporting that Beyfortus and the maternal vaccination are both very effective against preventing hospitalization and severe infections as well. I actually have a paper that's accepted but is currently under embargo with some US-based data that John Pelletier down at Akron and some very smart data scientists down there took the lead on. So definitely more to come. This is obviously such a huge advance for humanity. I'm the token old guy on the podcast today, so I can remember when I was a resident during winter, you would get just as many RSV patients, you'd get rotavirus patients as well, because every kid got rotavirus and they all got dehydrated and it was gross and common, and now we don't see it at all. So, as a bronchiolitis researcher, it'll be definitely a different thing when RSV is hopefully a thing generally of the past, but it's going to be great for our patients and their families.
Oh, absolutely. Gosh, we've really gotten into it with you guys, both with your clinical practice and your thoughts about the existing body of work. Moving forward, what is the most pressing research question when it comes to critical bronchiolitis? What are you most excited to work on?
Yeah, so I'll offer two things. So one we've touched on a few times already, which is really just the fact that bronchiolitis is a syndrome. It's not a disease. It is not DKA where there's a single pathway that we just put every patient on. And so developing these phenotypes that a lot of people are doing work on right now is really important, but also making sure that they are actionable phenotypes. So not just saying that kids with these cytokines have a higher chance of developing asthma or that's associated with certain treatment practices, but really trying to figure out objective markers at the bedside that we can use to guide bronchodilators and steroids and antibiotics and high flow and CPAP and all the other elements of care. The second thing I'll throw out there, and this is kind of a personal research interest, is that I think us intensivists don't realize how many children that we take care of in the ICU don't recover fully to their baseline even months later. When I was growing up, I kind of viewed bronchiolitis as honestly kind of an annoyance. These kids fill up our units. Some of them get sick and get intubated. Most of them don't. And they all basically recover and go to the floor and live their best life. And our research group and now some others have published some pretty interesting data showing that about 10 to 15% actually have not recovered back to their baseline even months later. And so figuring out which of these children are at risk for neurologic and pulmonary morbidity to me is really interesting. And even kind of beyond that, like children with bronchiolitis are, to use a really bad metaphor, like they're sort of like the lab mice of the ICU. They're children that are generally otherwise healthy. They have single organ failure, and they get exposed to all sorts of an intense dose of critical care, of sedation, of NPO status, of immobilization. And if we want to best understand how to sedate our patients, how to prevent and treat post-intensive care syndrome, to me, children with bronchiolitis is a ripe patient cohort to study lots of elements of critical care in.
Yeah, and I'll echo a lot of what Steve is saying. I think there's just so much heterogeneity. Like between the four of us, we've all discussed different ways that we target and what we do for bronchiolitis, and it's the most common diagnosis that we'll see in our careers. So I think the finding if there is more precision medicine or more of a pathway for like, this is what this patient will benefit from is like very interesting and cool to think about. And then the latter part of what Steve was saying is the patient family experience. Like these families are thankfully like only dealing with bronchiolitis. And to us, again, like kind of boring. They come in, they leave, and it's a high turnover. But I always tell the fellows, like, it's really thankful that these families don't know about ECMO and they don't know about intubation and they don't know about needing like a femoral line for vasoactives. But the stress that that family is feeling is still pretty immense. And especially like the younger patients that we're dealing with, like sometimes it's new moms that are dealing with like a 5 or 6 week old baby that's coming into the hospital. That level of stress, I don't think we have quantified or even like thought about like what impact does that have on how people are interacting with like healthcare. And that's kind of where my like interests are in alignment of like, how do we talk to these families? What support are we giving them? And like from a long-term like outcome standpoint, like how do they feel that we did from like a just customer service of medicine aspect?
That's such a good point, because to us, it really can feel like just another bronchiolitic. But to these families, it's often like literally the worst night of their life. Their otherwise healthy child's now in the intensive care unit. The doctor said they might have put a breathing tube in. That is such a traumatic experience that is really important to be attentive to us as clinicians and potentially as researchers as well.
Yes. Well, as I move to close this, Dr. Jatinder Dhami, Dr. Steve Shein, this has been incredible. We're so excited to share this in the fall, coming up the bronchiolitis season. As we close, any last words, anything you wanted to emphasize for the listeners today?
Be patient, both with yourself and your patients and their families.
Yeah, I think that this is one of those times that in the ICU, less is more, and don't just do something, stand there is often a good approach to children with bronchiolitis. And thank you again, Alice and Zach, for the opportunity and invitation.
Yeah, thank you guys so much. It's been really fun talking about this topic.
Do you guys teach your residents about the pores of Khan?
No.
Is that an outtake?
It's not an outtake. It's the inadequately developed collateral ventilation. It's my fun fact for residents. You're like, no, focus, get back to rounding, Alice. It's boring.